Thank you, chairpersons, for kind introduction. Thank you, Dr. Kamal Sharma, for giving me an opportunity to talk on a very important topic, the challenges in diabetes care in our country, in India. What I'll be talking in next 20-25 minutes, the different challenges. I don't have any conflict of interest for this particular talk. This is a very interesting slide and very important slide, which was published in Lancet Global Health. And it is talking in 2018 how in 25 years, from 1990 to 2016, the number of people with diabetes in India increased from 26 million to 65 million. And this shows that how diabetes in India is increasing in last 25 years or 30 years. This is a slide of 2019 IDF Atlas, which is talking that we will be projected maybe in 2013, 2045, we will be having a lot of people with diabetes, around 100 million, 134 million. But whatever the projection which was done or prediction which was done by IDF or WHO, actually India got those numbers before 5 years. So whatever the number which is predicted in 2030, we may have 100 million, but we don't know in 2025 this number we may have. We have other major problem that 50% of our patients are actually not diagnosed with diabetes. Our national prevalence is 8.9 and 1 million people are dying because of diabetes. So that's a sad story about diabetes in our country. If you see 2021, the data shows in IDF that again, increase in our country, it will be like 68%. So I mean, in Southeast Asia, the number of people from last IDF Atlas to this IDF Atlas, and probably in 2045, it will increase by 68%. As I already told you, 50% of them are not knowing the diabetes. But if you see all over the world, 4 in 5 adults with diabetes, they live in low and middle income countries. So actually diabetes is a major problem of the countries which are developing countries or low income countries. So India, China, they are the major problem in our country in compared to the Western world like America or Europe. So the problems which are associated with diabetes care in our country is one is huge burden of diabetes and its complication. We have several issues of diabetes care, which includes socio-economic factors and medical infrastructure. We don't have appropriate monitoring. So follow-up of patient is very much poor. Access to healthcare is poor in several parts of our country, and the financial burden of diabetes, both on the patient and national economy, is very, very high. There is a non-adherence to recommended guidelines, and that results in an inappropriate care. There are some distinctive features of type 2 diabetes in our country. There are genetic predisposed, as we are more having high waist circumference, still we have low BMI. The waist hip ratio is more, high visceral fat, we are highly insulin resistant, and high prevalence of atherogenic dyslipidemia with early beta cell defect. There are environmental factors like economic prosperity is increasing, but because of economic prosperity, there is a faster urbanization, decreased physical activity, and nutrition abundance is high intake of refined cereal and low intake of dietary fiber, fruit, and vegetables. This all leads high incidence of diabetes, which is occurring in young age. We are getting diabetes at a lower BMI. We are getting more complication. Heart disease is more prevalent, low prevalence of peripheral vascular disease, but more of coronary artery disease, and very high incidence of even microvascular disease also. But even after these so many problems in our country, the biggest problem is that there is a low awareness level, and this increases the management issue. High prevalence of undiagnosed patients, unaffordability of care, unavailability of trained medical and paramedical personnel. And these all are important issues which we have in our country. So in spite of higher prevalence, we have very low awareness in our country. 40% of our patients are unaware that diabetes can cause neuropathy. But I just want to give one very important example that 53% they believe that eating Kerala or methi can cure diabetes, which is not true. So I mean, people just eating the Kerala and they feel that diabetes can be cured. And this is what I'm seeing even in the urban areas. Staying in the Gujarat or in Ahmedabad also, we are seeing that a lot of patients feel that just by taking something kadvo kadiyat or eating Kerala, it may cure the diabetes. And this type of awareness is in our country. And that's a major challenge in our country. Now, I just wanted to give you the 2-3 slides, which is talking that how many people in India are actually having good glycemic control. So forget about those who are not diagnosed. Those who are diagnosed, 80% of them are not having a good control of diabetes. Only 19.7% were found to have a good control. And this is a Mohan paper which was published in 2007. Now let me talk about one more paper from Unni Krishnan. It is in 2014. Again, this paper is being taken by ICMR in diabetes study, which is the principal investigator was Dr. Mohan. And in that study had also shown that 70% of our patient HbA1c is remaining more than 7. So I had shown you the paper of 8. I had shown you the paper of 2014. Again, you see the third paper, which is again from the Ramchandran and group, and they are talking in 2020. The status is same. Still, the number of patients who are achieving good glycemic control is only 22.5%. So what it means, the three paper which I had shown from 18, 8, 14, and in 2020, even with so many newer molecules had come, so many new combination of therapy, so many CME in educational program which we have done, still at the level of glycemic control, the patients are not getting good control. 80% or 75% of them are not achieving the tight glycemic control. We are having one of the country who is with the rule of half, that half of our patients are not diagnosed. Half of them who are diagnosed, they don't receive the care. Those who are receiving care, they don't achieve the target control. Those who are achieving the target, still they are not having the desired outcome. And I will put here not the desired outcome, rather than half of them will not able to get even the control of all three aspects of the diabetes control, with A1C, blood pressure, cholesterol, along with obesity control, diet, exercise compliant, and smoking cessation. So if I put all these things, probably out of all 100 patients, maybe 2 or 3% of the patients we may have a desired outcome for our patient. So this high burden of diabetes, but high burden of complication also. At any given point of time, and this is paper again from Ranjit, it talks that even in the clinic, we can see that a lot of patients who are coming to our clinic, not just having diabetes, but they have a lot of diabetic patients, they come with the complications. So a huge burden of diabetes complication. This is very nicely written by Dr. Anup Mishra in a Lancet, that what are the challenges? There is a low educational status, poor awareness, delay in seeking treatment, poor access and adherence to medication, socio-economic and socio-cultural changes, which are contributing inequities in prevention and management, coexistence of communicable diseases like tuberculosis, HIV, and now like COVID, heterogeneous dietary behavior for community and religious practice, gestational diabetes is very high, adoption of alternate system of medication, diabetic peripheral neuropathy is otherwise also high, and again practicing of walking barefoot in a religious places, which increases the risk of diabetic foot, and access to trained physician and educator is really inadequate. So if I just put all these are challenges which are there in our country and how we can improve. One is probably early diagnosis. So delaying diagnosis itself increases the risk of complication. Early provision of basic treatment, and that treatment should be available across the country, even at the rural area also. We have to upgrade the skills of physician, and that is what we are doing in last 2.5 years. So 2 years, because of this COVID situation, one big advantage is that now we are reaching to the rural physicians. We are reaching to thousands of the doctors across the country, and we can train them online. It is more cost effective because nobody is wasting their time. The money is also very much less, and then still we can upgrade the skills of physician. And we have to find out some specific solutions which are affordable. And probably this is one of the solutions, a online, a teleconsultation, and online education itself. Regularly updating National Diabetes Management Guideline, which also we have started in last 2 years. And with the support of USV, RSSDI, nationally we are promoting our guideline, RSSDI guideline, Indian guidelines to each and every district. We have identified 745 districts with the district coordinator, and they are regularly, we are updating about all national diabetes management guidelines too. So early diagnosis is a need of our, it's a timely diagnosis, early and aggressive management will definitely delay the complication. And we know that this is going to give us the legacy effect. And this we know from UK PDS data. If you can achieve a tighter glycemic control, probably for long term, you are going to have less and less complication. But at the same time, we must know, and for all those clinicians who are here, they should know that bad glycemic legacy also increases the risk of complication. So if somebody could not have early glycemic control, this bad glycemic legacy will also continue throughout the lifetime, and patient will have more and more complication throughout the lifetime. That's also very important. So early aggressive control is very important. If we can't control early, then to undo bad legacy is very, very difficult. So those diabetologists, we all know that once the patient comes to us, it's already 10, 15 years of uncontrolled diabetes. Now we can't do much. Even we do best of the best treatment, we can't undo the bad legacy. Whatever the patient had a complication or the chances of getting complication, probably patient may have it. And if we want to have a good legacy, then early and aggressive management is must, and that is done by primary care physician, not by diabetologist. So where we are, we should get early diagnosis. This is what we are trying. We should improve the access to diabetes care. That is what constantly we are trying from the organization. We should have an aggressive management for tight glycemic control, and that is what we could learn more in last 20 years with a newer agents. Screening of the complication, that's very, very important. Glucocentric approach, now we changed to the complication preventive approach in last 5 years, after we know the data of these newer drugs that they can prevent the complication, and we had become more precise in treating diabetes. That is with the advantage of continuous glucose monitoring, and we are also trying that how we can prevent the diabetes, particularly for high risk population, by increasing the awareness. And this is all what we are doing through Diabetes India, by RSS, GI, and by multiple organizations across the country. But can we change the natural history of type 2 diabetes? If somebody is talking that if we get the diabetes, can we reverse it? If somebody at the high risk of diabetes, can we prevent it? And can we primordially prevent the diabetes itself? Because that is what otherwise we will continue to increase the diabetes in our country. Yes, we can do it. Let me start this story with the 2004 paper from Lancet, where Dr. Yagnik had talked that Indians are thin fat Indians. We get diabetes even with less fat. We get diabetes at an early age. We get diabetes at a lesser BMI. Why? Because we have higher insulin resistance. We have more fat, and we are thin fat Indians. We have more fat and muscle mass is less, while the European phenotype is more muscle mass and less fat. This is we know from 2004. So, I mean, this is a paper which is published long back. And even in his YY paradox also, he talked that even his BMI and his Professor Yudkin BMI was same, but still the fat percentage in Dr. Yagnik was more in compared to Europe. Now, if you see this data, this paper, that globally, we are the one who get maximum low birth weight child, even more than Africa and some other countries like South America and some other countries like in Syria and all this country. So we Indian subcontinent, which includes India, Pakistan, Bangladesh, Sri Lanka, and these 4 or 5 countries, we get maximum low birth weight child in the world. And at the same time, if you see diabetes point of view, we get more diabetes also. So we are capital of the two. One side we have undernutrition, other side we have higher incidence of diabetes. And this means, this dogma is mean that we are having more of a undernutrition, more of a low birth weight child, and still we get more diabetes. So there is a connection between that. And this is the connection that we get a small, thin, fat Indian baby. Again, Yagnik had produced this paper in 2002, which is talking that we are small size, more fat, less muscles, less viscera, high insulin, high leptin, and low adiponectin even at the time of birth of a child. And that body composition is we have in compared to Western population. Even our Indian baby is born with 2.7 kg. The fat percentage is more than 20-25%, while a Western baby is around 3.2 with a fat percentage of less than 15 or 20%. So this is what from birth only we are getting high insulin resistance. And this Indian scenario, again, what happens? The child in early nutrition age, I mean in early childhood only, we just try to feed the child, increasing his adiposity. Instead of, we are not working on increasing his lean body mass, increasing his length. So in early childhood, in early pediatric age group or early adolescence group, we should work more on increasing lean muscle mass or increasing the length of a child or young adult rather than increasing their weight. If we increase their weight, even by few kg, it is going to increase their more adiposity, which is going to increase the risk of metabolic syndrome, increasing the risk of diabetes risk. While if we increase the lean muscle mass and length, probably we are going to decrease the diabetes risk throughout the lifetime. So this is what we have to work. We have to start working from these young children or these young adolescents, that how we can increase their lean muscle mass and length of the body rather than weight of the body. If the epidemic of diabetes in India is disease due to low birth weight child, we all know that this low birth weight child, more insulin resistant. Again, this become a most postnatal undernutrition, and this is going to become a undernourished, a small mother. And this small mother is going to have a child. If she is more nutrition is given, they are going to have a macrosomia, again obesity, again there is a fetal adiposity and eyelid dysfunction. So both the side, if the child is not developed properly, an undernourished mother, or if you make the obese mother, both are going to get the child which is of low birth weight. Or we may get a birth weight which may be higher, but it is because of GDM. So if the epidemic of diabetes in India is a disease due to low birth weight, undernutrition, or even overnutrition, that occurred within a generation, is last 30 years, if you see, or 15 years, 20 years, or 30 years, or 35 years, we will find in last 2 or 3 generations, suddenly this increase in diabetes incidence or metabolic syndrome. There is no reason why it should not be reversed. If we just change complete cycle, probably we can reverse on a similar time scale. So this is what we proposed, that after 2030, any child born after 2030, he should not see those diabetogenic risk factor in his lifetime. So we have to start work now for the young children, for young girls who are going to become mother maybe after 10 years, maybe the 12 years old girl or 10 years old girl or 14-year-old girl. We have to counsel them now to eat healthy, to become more physically active, and that will increase in their mass muscles. We have to make healthy mother with increased muscle mass, and they are going to deliver a healthy child if provided with proper food and nutrition. We are going to have a healthy kids, healthy young adults, and they should go in a school where we want to create them more healthy, and healthy school children, healthy young adults, and then probably we can think of a disease-free adults. And that is what our mission from Diabetes Care in India, from making it our country diabetes-free India by 2030, those who are born after 2030. It does not mean that we may not have diabetes after 2030. We wish, we have a vision that those who are born after 2030, we should not get those diabetogenic risk factor in their lifetime, so they develop diabetes in their early young age. With this, I thank. Once again, I conclude by saying that we believe we are at a time when we can change the natural history of type 2 diabetes, and doing so should benefit the health of millions of patients and will benefit healthcare system by reducing resource use and cost. With this, I thank once again. Thank you, Kamal, for giving me this opportunity. Thank you.